Manjula, are we live?
We are live now, doctor.
I'll start. So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. I am Dr. Vishal, a Scientific Committee Chairman, Rajasthan Ophthalmological Society, and it gives me immense pleasure to welcome you all for yet another masterclass of the online PG teaching program, Kaksha. Kaksha is a PG teaching program by ROS, which will cover all the major topics over a period of next 2 years of the current curriculum of postgraduate ophthalmology program. We'll be bringing the best of national and state faculty experts to share the knowledge and interact with you. The residents in the audience are also encouraged to put forward their doubts in a fearless manner. Today we have two hot seat residents. Ravina, are you here? Can you say hi?
Yes, sir.
Okay. And Surbhi. Surbhi, are you here? Okay, she'll be joining soon. Who are all final year residents from different colleges in Rajasthan. Coming to this class, we have today with us Dr. Jayesh Vazirani, a dear friend from Ahmedabad, to teach us about corneal dystrophies and corneal ectasia. It is a very important topic for the postgraduates and frequently asked in theory as well as practical exit exams. And Dr. Jayesh is an authority for the same. Just a brief about Dr. Jayesh. He is the director of Excel Eye Care, Ahmedabad, India. He trained in ophthalmology from PGI, Chandigarh, followed by a long-term fellowship in cornea, ocular surface, and refractive surgery at the prestigious L.V. Prasad Eye Institute, Hyderabad. He has worked as faculty in the same institute, engaging in clinical care, research, and teaching. His work has been published in multiple peer-reviewed journals globally. His area of interest include complex ocular surface disorders, limbal cell transplantation, lamellar corneal surgeries, and keratoprosthesis surgeries. I now welcome the ROS President Sanjeev Desai, sir, President-elect, sir, Dr. Virendra Agarwal, and our dynamic secretary from Jodhpur, Dr. Ghulam Ali, who is also our moderator for the evening. Over to Dr. Jayesh for his class. Jayesh, you can start sharing your screen.
Thank you so much, Dr. Vishal. It's a pleasure to be addressing the residents today. I hope I'm audible.
Yes, sir.
Yes. So I just start sharing the slides. Right. You should be able to see the first slide full screen right now.
Yes.
Right. Thank you. Then we'll start off. Right. So the plan for the evening is to go through some of the basics of corneal dystrophies. That's the main focus today. And then if we have time and stamina left over, we'll go over some of the brief management points about keratoconus. So we do get financial support for our meetings, sometimes travel related from various companies, but none of these have any bearing on the subject matter of the discussion we are going to have today. At the outset, I would like to acknowledge the help given to me by Dr. Nikhil Agarwal, as well as his residents from the All India Institute of Medical Sciences, Jodhpur. They have kindly shared with me some of the slides that I will be showing you today on the specific dystrophies. Yes, is there something, a question, Sumit? I just heard something, no. Right, so the objectives for this talk are for the residents to understand what is a corneal dystrophy, to appreciate the difference between the conventional classification schemes for corneal dystrophies and the more recent classification schemes, because there is a major difference. To be able to describe major corneal dystrophies, because I understand that you might be asked to describe these in general as a long question or specific subsets of dystrophies as a short note. You may also get certain questions on OSCE or MCQs from these, so we'll try to cover whatever we can. And I'll just be touching on the basic principles of management, because the in-depth management of each dystrophy, I feel, is a little too advanced at this level. So almost all of my content for the presentation today is sourced from these two articles. So I strongly recommend that this is essential reading material for all postgraduate residents. These are two articles published in the Cornea Journal, and these are free to download. You can search on PubMed, Medline search, and you'll get them. One is published, the earlier one is published in 2008, which was the first IC3D classification of the corneal dystrophies. IC3D refers to the International Committee for Classification of Corneal Dystrophies. This was a panel set up by the Cornea Society. And then subsequently, there was a revised classification that was published in 2015. And I'll elaborate what are the differences between the two versions. But this has extensive material on all corneal dystrophies. And if you just read these two articles, I think for all practical purposes, you will be very thorough with corneal dystrophies. So a little bit of history. The word dystrophy itself, when applied to this condition, in particular corneal dystrophies, is a little bit of a misnomer. This word was first used in medical literature about more than 100 years back, about 140 years ago, by Wilhelm Erb while describing muscular dystrophy. And when you see ophthalmic literature, it was Gronau who described two patients with one having granular corneal dystrophy and the other had macular corneal dystrophy. And this was in 1890. Fuchs has contributed in a great manner to all kinds of our ophthalmic literature. So he used the word dystrophy to refer to any ophthalmologic disease that resulted from lack of nourishment or hormones or blood supply or nerve supply to that tissue. So that was the hypothesis at that time. This, you must understand, is before we had slit lamps or a greater understanding of tissue and pathogenesis. So dystrophy is a term that has stuck, but actually the literal meaning of dystrophy, which is lack of nourishment, has nothing to do with corneal dystrophies. So we define a corneal dystrophy as a group of inherited corneal diseases that are typically bilateral, symmetric, slowly progressive, and without relationship to environmental or systemic factors. Each of these phrases is important because if you have conditions that fulfill all of these criteria but are not bilateral, it is unlikely to be a dystrophy. Likewise, you have certain conditions which are called degenerations. For example, you have spheroidal degeneration of the cornea, which will fit all of these descriptions, but it is not inherited. And it also has environmental factors which are responsible. Likewise, keratoconus, and this is controversial, keratoconus, one could argue, is inherited, is bilateral, is symmetric, is slowly progressive, and therefore fits the description of a dystrophy, but till now has not been actually included into the classification of dystrophies, mainly because a lot of cases of keratoconus do not have a defined genetic basis, and also because we have definite environmental factors, for instance, ocular allergy and eye rubbing, that contribute towards the progression of keratoconus and may also contribute towards the origin of keratoconus. So right now, keratoconus and other corneal ectasias have been kept out of the classification of corneal dystrophies. So the first attempt to classify corneal dystrophies was probably in 1938, where differences were laid out between granular dystrophy, lattice, and macular corneal dystrophies. And later on, subsequently, there have been published a lot of textbooks, a lot of book chapters, and certain articles that have tried to classify dystrophies. Conventionally, these have been based on anatomy. So based on the layer of the cornea which is involved, the dystrophies are classified into either epithelial and subepithelial, the second being the Bowman layer dystrophies, the third being the stromal dystrophies, and the fourth was the Descemet's membrane and endothelial dystrophies. You'll notice the two asterisks that I have put here because these are the two classification categories that have been revised in the most recent classification. Now, compared to this anatomical classification, which was mainly based on the phenotype, the clinical phenotype, or what you could examine on the slit lamp, the recent classification, the papers that we just showed you from 2008 and 2015, focus more on genetics. So they have divided the classically divided anatomically based corneal dystrophies into certain categories. These categories are C1 through 4. So C1, C2, C3, and C4. And these numbers 1, 2, 3, 4 refer to the level of evidence that exists in a genetic sense. So if the evidence is very strong from genetics for a particular dystrophy, it will go into category C1. And if the evidence is very weak or non-existent, it will go into C4, with C2 and 3 being intermediate categories. So these are the three things that one conventionally describes while describing a dystrophy. So for example, if you have a question on epithelial dystrophies or stromal dystrophies or dystrophies in general, this is how you would try to frame your answer. First, start off by describing the demographics and the clinical appearance of the condition. Second would be a short description of the histopathology, what is visible on light microscopy. Electron microscopy findings are generally not expected. And the third would be the genetics. How is it inherited? And if you can manage to remember the specific chromosome or the genetic mutation, it is very good. So these are the categories that I was referring to. So category 1 is a well-defined corneal dystrophy in which the gene has been mapped and identified, and we know the specific mutation that is responsible. Category 2 would be dystrophies that have been mapped to chromosomal loci, but the gene remains to be identified. Category 3 would be a dystrophy which is very well defined, but we do not know the chromosomal locus that is responsible. And category 4 is mainly for conditions that have been typically classified as dystrophies, but the evidence for it is not very convincing. So there is no genetic evidence to say that it is a dystrophy, and therefore it is a questionable inclusion in the classification of dystrophies. This is the original IC3D classification from 2008, and this is a screenshot from the paper that I just showed you. And you will notice that you have the 4 categories that I showed you: the epithelial and subepithelial dystrophies, Bowman layer dystrophies, the stromal dystrophies, and the Descemet's membrane and endothelial dystrophies. Compared to this, there have been significant changes made in the revision that came out in 2015. The first important point to note is that Bowman's layer dystrophies and Descemet's membrane dystrophies have been removed. So now you don't have specific layer dystrophies, as in the acellular layers of the Descemet's membrane of the Bowman's layer. I'll show you the classification in the next slide. The second change is that the epithelial stromal dystrophies that are caused by mutations in TGF-beta1 gene have been reclassified into one category. The table of gene loci and genes with specific mutations has been removed, as it was very long and cumbersome. And optical coherence tomography or OCT findings, wherever they've been described, have been added in this paper. One very important change is that earlier we had 2 types of congenital hereditary endothelial dystrophy described: CHED or SHED1 and SHED2. So classically, SHED1 was believed to be inherited in an autosomal dominant fashion, and SHED2 was believed to be inherited in an autosomal recessive manner. Now we know that the genetic basis for what we used to call SHED1 or autosomal dominant SHED is the same as what we see in another corneal dystrophy called posterior polymorphous corneal dystrophy, or PPCD. So now SHED1 no longer exists as a separate dystrophy. It is merged into PPCD. So now we have just congenital hereditary endothelial dystrophy, or CHED, which was earlier SHED2 or autosomal recessive SHED. Is this part clear? Because this is, I believe, an important slide. And if any of the residents have any questions related to this, we can address them before we go ahead. Right. So this is the table from the paper from 2015. So you do still have epithelial and subepithelial dystrophies, and this is the list and the categories from C1 to C4. We will not be going into the details of each dystrophy, but I'll tell you which of these are seen more commonly in the clinic, and we'll describe in detail some of those. So I'll be telling you a little bit more about EBMD, or epithelial basement membrane dystrophy, from the first category. The second category, if you notice, is no longer Bowman's layer dystrophies. It is epithelial stromal TGF-beta1 dystrophies. So all of them have a common genetic basis, the TGF-beta1 gene, but they can affect both the epithelial as well as the stromal layers. So you have Rice-Buckler's dystrophy, Thiel-Behnke dystrophy, lattice dystrophy type 1 and its variants, and you have granular type 1 and type 2. So all of these will be going into detail because these are commonly seen in the clinic. Then you come to the third item on this table, which is the stromal dystrophies, where you have macular Schneider dystrophy, congenital stromal corneal dystrophy, fleck dystrophy, a lot of them. But from these, we'll be describing macular corneal dystrophy in some detail. And then the last category is the endothelial dystrophies. Note that this is no longer DM and endothelial dystrophies, but just endothelial dystrophies. So here we'll be going into some details of Fuchs endothelial dystrophy, which is FECD, and also CHED. Right. So starting from the superficial ones to the deeper layers, EBMD, most cases are sporadic in the clinic, but the cases with autosomal dominant inheritance are the ones where the TGF-beta1 gene is involved. So this dystrophy can be just picked up as an incidental finding in the clinic. Most commonly, when you see a patient, you will see a patient who complains of multiple episodes of severe pain. So these painful episodes are due to recurrent epithelial breakdown or what we call recurrent corneal erosions. So this is the pattern that you see in diffuse illumination in slit as well as in retroillumination. So you can see these map-like patterns on the cornea, which is the photograph A. You can have dots and you can have these fingerprint-like lines. So that is why this dystrophy, EBMD, is also called map dot fingerprint dystrophy. In general, in the clinic, whenever you are examining a patient where you are suspecting corneal dystrophy, this is the classical way in which to examine. You should examine under diffuse illumination with a slit or a broad beam both so that you can make out the level of the lesion, as well as in retroillumination to pick up the subtle changes. The histopathology typically will show that you have excessive basement membrane material between the distorted epithelium and the intact Bowman layer. So it's at the epithelial level where most of the changes you will have. What is the management for EBMD? It is symptomatic. So most cases are not very visually significant. Sometimes when you have recurrent episodes of erosions and they scar again and again and again, you can have a sort of superficial fine haze. So they are treated symptomatically with lubricants, with hypertonic saline or ointment. Sometimes if you have epithelial breakdown, placement of a bandage contact lens will suffice for the epithelium to heal. And if you have recurrent corneal erosions again and again and again, and they are very painful, all of these techniques are useful to reduce the intensity as well as the frequency of the episode. So you can do simple debridement at the slit lamp. You can use a diamond burr, or you can use excimer laser PTK to do it. One can also treat very localized areas with anterior stromal puncture to induce some scarring there. And what is very effective in recent literature is a procedure called alcohol delamination, where the frequency and intensity of the episodes is controlled. It's important to note that this is one dystrophy where keratoplasty does not give good results. So I would go to the extent of saying that doing a lamellar, deep lamellar, or even a penetrating keratoplasty is counterproductive. And I would say it is contraindicated because you are not treating the actual cause of the dystrophy. So the new corneal tissue that you put in, till the donor epithelium is intact, it will look good, but very soon it will be replaced by the recipient epithelium. And then you will start again having the same kinds of issues with recurrent corneal erosions, and that is much more difficult to treat on a graft. So please do not advise or do any kind of corneal transplants for EBMD. Rice-Buckler was classically described as a Bowman's layer dystrophy. Now it is part of the TGF-beta1 group. So these dystrophies have overlapping features. It's the same gene, it's the same protein which is responsible for this. So this also, you can have recurrent corneal erosions. You may have vision impairment, and you'll notice this kind of haze at the subepithelial and the Bowman's layer. Sometimes the deeper layers are also involved, and therefore it becomes a little confusing whether it is Rice-Buckler or granular dystrophy or some other kind of dystrophy. And the typical histopathology findings are described in the paper, where you'll see deposits of what is called keratohyalin beneath the epithelium and between the superficial stromal lamellae. Kale-Benke corneal dystrophy or TBCD is very similar to Rice-Buckler, and quite often, if you read the earlier literature, the papers have not been able to distinguish between these two. So a lot of papers which describe Rice-Buckler dystrophy actually mean TBCD and the other way around. This is also the same TGF-beta1 gene. And what you'll see is this kind of honeycomb appearance. That is how it is classically described at the Bowman's layer. And the honeycomb opacities are very clearly made out. They are bilateral, usually symmetrical. And if you look at the pathology, you will see that there is fibrosis, there is scarring at that layer, which replaces the Bowman's layer. So the treatment for these two dystrophies, again, if they are very superficial and the main issue is recurrent epithelial erosions or breakdown, it's the same as what I described with the EBMD. So symptomatic treatment with eye drops, bandage contact lens placement, and procedures like stromal puncture or alcohol delamination. If you have involvement of the stroma, which is significant, let's say up to 150 to 200 microns, one can do a phototherapeutic keratectomy using excimer laser to ablate that tissue. One can also do superficial transplantations such as manual technique, which is called an SALK, superficial anterior lamellar keratoplasty. The same procedure can be done with greater finesse using a femtosecond laser. If one has access to it, then it's called an FALK. Next, we come to lattice type 1 or the classic kind of lattice dystrophy. So again, the same gene which is responsible, it is autosomal dominant. The onset of the lesions is usually within the first or second decade. So you can see it in children or teenagers. And these patients will have, if the lesions are superficial, you can have certain fleck-like opacities. And then later on, they go on to develop branching refractile lines that are typical of lattice. The lesions can then be subepithelial and involve various layers of the stroma. So they can go, they start centrally and superficially, but then they spread out into the cornea and also go deep. But usually the far peripheral stroma is spared. So these are the kind of pictures that you can see with lattice dystrophy, the classic kind of lattice dystrophy. The first picture shows you just faint fleck-like opacities where the lattice lines are not very prominent. Whereas the second and third pictures, particularly in the retroillumination picture, you can see these kind of spidery lines, which are typical of lattice dystrophy. So again, in the early stages, this is not very visually significant. And it is only when these opacities become confluent and you have very significant visual impairment, this would be post 40, 50 years of age that you would need to intervene. So this is a variant of the classic lattice. The first variant, the picture A, shows slightly thicker lattice lines, which are more central, and this is called type 3A. And the type 4 is picture B, where you have minimal findings of usually fleck-like opacities. But if you look carefully in retroillumination, these flecks are also associated with lattice lines. So this is easy to miss or rather misdiagnose as a granular dystrophy. And because these lesions are not very superficial as compared to EBMD or Rice-Buckler, you will not have recurrent corneal erosions. What you'll have is anterior to mid-stromal lesions, which usually are not very, very visually significant. This is the pathology. So lattice in the cornea is basically due to amyloid deposits. And amyloid, as you would know from your pathology in MBBS, stains very well with Congo red. Right. So this may be an MCQ because this is one specific stain that you use to pick up amyloid in the cornea, and that is commonly asked. You can also see the birefringence if you have that kind of microscope, what is described as the apple green birefringence. So what is lattice type 2? So lattice type 2 is actually a systemic disorder where you have systemic amyloidosis, which can affect mainly the skin, the nerves, and sometimes also the solid organs. And then the clinical picture in the eye is very similar to your classic lattice or lattice type 1. So this patient has a mask-like facies, which is typical of amyloidosis because the facial nerve palsy is a major feature of this. So if you have classical findings of lattice, but you also have systemic amyloidosis, then it becomes lattice type 2. Next is granular corneal dystrophy, again a TGF-beta1 dystrophy. So you have classic or granular type 1, where the onset is very early And the early symptoms are usually glare and photophobia. And because the lesions can be superficial, you can have recurrent erosions. And then they become more and more confluent. So this is how the lesions look like. You have these verticillate opacities, which are also described as breadcrumb-like opacities, sparsely spread out into the cornea. They are not usually spread out limbus to limbus, and they are at multiple levels in the stroma. In more advanced cases, you can see this kind of snowflake appearance, which pretty much covers the entire cornea. The pathology again will show deposits of keratohyalin. It's important to note that granular corneal dystrophy in itself almost will never merit a corneal transplant because the lesions are spread far apart. The visual acuity is usually very well preserved. And if a patient like this comes to you at, say, 60, 70 years of age and says that I'm having blurry vision for the past year or 2 years, usually the cause is the cataract, which if you dilate and see, you can be sure of, because this dystrophy has been there in the eye for many years. It is there since childhood, but the visual symptoms develop after the onset of cataract. So rather than doing a triple procedure or a combined corneal transplant with cataract surgery, it is safest and best for the patient to just do a cataract surgery for these patients. Granular type 2 is the onset is usually in the first decade of life. The lesions can be superficial and then can also be deeper, but usually these are more discrete. So you have very few lesions compared to the type 1. You can have just a few dots which are picked up on incidental examination. Again, these are not very visually significant. GCD2 in later stages can sometimes become very confluent. The picture which I have showed you in D is one of the rare instances where you would need to intervene. Otherwise, usually these are not very severe. Next is macular dystrophy. So macular dystrophy, again, the onset is in childhood. And here you can have significant visual impairment, which usually is in adulthood. This is how the lesions start off like. So you will see a few central macular opacities. The pathology shows deposits and accumulation of glycosaminoglycans at all levels of the stroma. And you can actually have limbus to limbus involvement in this. So I have bunched all of these together in the management principles. So if you have lattice, granular, or macular dystrophy, if it is superficial, you can do something like an SALK, FALK, or PTK. For deeper lesions and visually significant lesions, this is particularly true of lattice. DALK or a deep anterior lamellar keratoplasty is a very good option. As I said, granular dystrophy rarely ever needs a corneal transplant procedure. And the penetrating keratoplasty still has a role, particularly in cases of macular dystrophy. This is important because even though macular dystrophy is described as a stromal dystrophy, almost all of these patients also have involvement of the Descemet's membrane and the endothelial layers also. So if you look carefully on the slit lamp or on the ASOCT, you will pick up a thick DM. And if you have significant deposits at the DM level, it is actually better to do a full thickness or a penetrating keratoplasty for macular dystrophy compared to doing a DALK. Right. So we will finish off with the endothelial dystrophies. And this is probably the commonest dystrophy that you'll see in your clinical practice. And it's also commonly missed. So usually the patients with Fuchs dystrophy that come to me are patients who have undergone cataract surgery in one eye. They have developed postoperative corneal edema. And then we look at the other eye and we see the typical findings of thickening of the DM. We see the gutted changes. And then we realize that the patient had Fuchs dystrophy. So it's very important to look at all your patients of cataract surgery very carefully at the endothelium using the technique of specular microscopy on the slit lamp itself, even if you don't have a clinical specular microscope, and also in retroillumination to look for the guttata, and you won't miss it. So Fuchs dystrophy in most cases will be asymptomatic. It's only in advanced cases that the patients will start developing early morning visual symptoms, which gradually go on to become progressive and persistent throughout the day. Later on, if it is very advanced, you can have involvement of the stromal layers because the edema is long-standing that causes fibrosis or scarring. And in the last stage, you will have epithelial bullae, recurrent erosions, and scarring throughout the cornea. So in retroillumination, the gattata are very clearly visible. You can also see them if you do a careful slit lamp examination with the specular reflection. And in the later stages, you can see epithelial corneal bullae. The microscopy will show cornea gattata, which are focal excrescences at the level of the endothelium. You'll see a thick DM compared to usual. And then you will have the findings of stromal edema and also intraepithelial edema. CHED, as the name suggests, is congenital hereditary endothelial dystrophy, so seen in children. Earlier, as I told you, it was classified into CHED 1 and 2, but now you just have CHED, which was CHED 2 earlier. So it will lead to corneal clouding, which can be mild, moderate, or significant. So typically, you'll see these patients who have not been diagnosed at birth or very early after birth, but maybe at 5, 7 years of age, 10 years of age, they present to you. If the patient or the child has good vision, is able to study, is able to carry out all other activities without any difficulty, it is best to observe these cases. However, if you have significant corneal edema, significant impairment of vision, endothelial keratoplasty is the standard of care treatment. So a DMEC or a DSEC will give you excellent results. The pathology shows edema of the basal epithelial cells because there has been long-standing edema. So you'll see that you'll have breaks in the Bowman's layer and you'll have thickened Descemet's membrane with no visible endothelial cells. The treatment for endothelial dystrophies in general is, if it's a very advanced case and you have bullae and ruptures and you temporarily want to fix it, you can use a bandage contact lens for symptom relief. You can use drops. But the standard of care treatment these days for endothelial dystrophies, as I said, is endothelial keratoplasty. In very rare cases, one might need to resort to penetrating keratoplasty. Now, if you are in Viva, I think your examiners might be interested more in Fuchs dystrophy than anything else. So some of the questions that you might be asked is, when do you do just cataract surgery in a patient with Fuchs dystrophy and cataract? When do you do a combined endothelial keratoplasty with a cataract surgery? So it's a long topic, but in brief, I'll tell you that if you have edema, you should do a combined procedure. If you have no edema clinically or on your pachymetry, whatever way you measure the pachymetry, one can do just cataract surgery and explain to the patient that later on, if the corneal decompensates, you may need an endothelial keratoplasty procedure. Right. So any questions on any of the dystrophies that I described before we go on to the quiz questions? I hope everyone is still awake.
Yes. Dr. Ron, you have any question?
No, sir. We don't have at the moment in the question and answer session.
There's when to do EK in Fuchs dystrophy?
Right. So Fuchs dystrophy, sir, typically patients will be presenting at more than 50 years or 40, 50 years of age. So if they have good vision, if they have no edema, and they have just the clinical findings of a thick Descemet's membrane with gattata, I would not advise any intervention. However, if they have started to develop focal, central, paracentral edema, that is the indication for an endothelial keratoplasty. So if they have, in most cases, they will have a cataract at that stage. So it's best to take out the cataract and also simultaneously do the EK.
And what type of cataract surgery will you do if you have Fuchs? What is the standard of care?
Right. So the cataract surgery should be done as per your comfort zone. So the surgeon has to decide whether they feel that particular cataract in their hands. If they are comfortable doing phacoemulsification, it is perfectly justified to do phacoemulsification. One would use techniques like coat the endothelium with dispersive OVD. Some of the other tips that I give cataract surgeons is to always do it slowly and use as less energy as possible. Try not to use anything except for a monofocal hydrophobic intraocular lens. At the most, one can use a toric lens if there is significant astigmatism. But I strongly discourage the use of any kind of lens with rings, that is an EDOF lens or a bifocal or a trifocal lens, because the gattata themselves cause light scatter. And if you add an IOL which has rings in it, it will cause dramatic loss in visual quality. Also, the refractive outcomes may not be very predictable in these cases, particularly if the patient has started to develop focal edema. What you'll notice is whatever outcome you get later on, if the patient needs an endothelial keratoplasty, you will have a hypermetropic shift. So if you have Fuchs with cataract surgery, what I typically advise is that the surgeon should aim for a post-operative refractive target of about minus 0.75 to minus 1 diopters. So that later on, if you have a hypermetropic shift, the patient doesn't go into the plus side. And the technique, answering the original question, can be phaco, can be SICS, can be ECC, whatever the cataract merits.
Thank you. And intracameral Trypan and Moxie.
So intracameral Trypan blue has almost no deleterious effect on the endothelium, contrary to what a lot of us believe. In fact, in modern endothelial keratoplasty, so if I'm doing a DMEC, I will actually put a lot of Trypan blue on the graft to stain the graft, and it has been shown to be very safe. About intracameral moxifloxacin, well, you have to stick to your normal practice pattern. My practice pattern involves no intracameral antibiotic use, so I would not use it. But if you are routinely using it and you are finding it to be safe, there is no reason to modify your practice pattern just because the patient has Fuchs dystrophy.
Thank you.
From resident, any question? Navina, Priyansi, Dr. Vinesh.
So I hope all of you understood that the reference material I was referring to, because after all this is over, what you need to take home is that you need to go back and get those 2 articles, and those are open access, and that will give you all the information that you need. The IC3D classification, the original classification, as well as the revised classification from 2015.
Just can you put link of that article in the chat box?
Yes, I'll do that. Once I stop sharing my screen, I'll do that. And I'll also send you the article so you may share with them.
Yeah, sure.
Right. So if there are residents, should we go on? I have just a couple of questions for the quiz.
Yes, sir.
Right. So I've been told that the residents are meant to answer the questions through the chat box, and the first person to type the correct answers wins the quiz, right? So I have a couple of questions. This is the first one. Okay. So the question here is, describe the 3 conditions, which is A, B, and C, and also tell us which one of these is not a corneal dystrophy. So you also need to write all 3. What is A, what is B, what is C? And then tell us which is not just which is not a corneal dystrophy. So the complete answer or the correct answer, which will have descriptions of all 3. Correct. So I still don't have the full answer. I'm looking at the chat box. So no one has typed the complete answer in one reply till now. Correct. So we now have the first correct answer from Ectasia, I believe. Right. So Ekta, you are correct. The first picture shows lattice dystrophy. The second one shows granular dystrophy. And the third one is spheroidal degeneration, which is not a dystrophy. It is a degeneration. We'll move on to the next question. So again, and I'll tell you that all 3 of these are dystrophies. So your answer should be, what are these 3 conditions? And which of these is a corneal transplant not likely to help? So what is A, what is B, what is C? And where would you not recommend a corneal transplant and why? I think we still don't have a correct answer yet, so you can keep trying. Some of you have some parts of the answer right, but none of you have given everything in one answer. So you do need to read up. So is that enough time, sir? Should we just close this? Because, okay, someone has part of the answer. Yes, I think Siddhi Mathur has got this right. So Siddhi's answer is A is EBMD, which she has spelled as EMBD, but I guess we'll take that. And I suppose she means that it is contraindicated. PTK is contraindicated, means the transplant is contraindicated. I suppose the typos are due to the speed of typing. B is Fuchs, and 3 is CHED. So that is the correct answer. We finally have a correct answer from Siddhi Mathur. So most of you felt that A represents Rice-Buckler or Thiel-Behnke or that kind of Bowman's layer dystrophy, but this is the kind of picture you'll see when a patient has had repeated episodes of corneal erosions in EBMD. And after that, when it heals, you'll see this kind of pattern. So it's a little difficult to pick up, but A is EBMD. You don't see the typical map dot fingerprint patterns here, which is described in the textbook. And actually, when you see your patients, they look like this, because it's very rare for them to present at that stage with map dot or fingerprint patterns to you like that. The second one just shows gutted changes, which are typical of Fuchs. The third is very classical for CHED. And the patient will benefit with an endothelial keratoplasty in Fuchs and CHED. But as I told you, in EBMD, transplants are not a good idea. Right. So again, any questions regarding anything that we discussed from anyone, residents, anyone else on the Zoom meet? Or if there is something that you felt you are asked in your exams or in your that we did not cover, but you would like me to answer, we can take that. Right. So if there are no further questions, I think we'll quickly go on to maybe 5, 10 minutes, 15 minutes of keratoconus, which is the main ectasia that we usually see. So I've been told that the earlier versions of this class have covered topography and how to read topography maps or tomography, and therefore you know mainly how to diagnose keratoconus. So I'm focusing on decision making. So the earlier talk on dystrophies you might have found a little theoretical, which is mainly useful for writing answers in exams. But this part is completely different. So keratoconus decision making is something that you will be asked to do almost on a daily basis in your clinical practice. So I have kept it very clinical, and I'm not showing you any papers or any literature. I'm just telling you how I decide about a patient of keratoconus when I see them in the clinic. So the first part of dystrophies was very much oriented towards your exams and Viva and MCQs and short notes, but this is what you should know as a clinician. So this slide, I have put together some of the common interventions that are available today for an eye with keratoconus. So you can have procedures such as corneal cross-linking, we have contact lenses, then we have the use of excimer lasers in different ways. For refractive correction, one can do implantable contact lenses or implantable collimator lenses. One can put different kinds of things, artificial rings into the cornea, which is ICRS, implantable corneal ring segments. There is a modification of these using allogenic corneal tissue, which is called corneal allogenic implantable ring segments, or CAIRS. One can also do these days Bowman's layer transplant, which has been described in recent years, which is a BLT. There is the gold standard for advanced keratoconus, which is deep anterior laminar keratoplasty, and also the classically and what has stood the test of time, penetrating keratoplasty. So what I want to do for you is to simplify this, when to use what and how. So these are the parameters for which you should judge any intervention in medicine. This is not just about keratoconus, this is not just about cornea or ophthalmology, but whenever you are looking at something and you are offering it to a patient and discussing with the patient as a potential therapeutic modality, you look at, is it safe? Is it predictable? What is the efficacy? Is it simple to do? And then based on all these, you calculate what is known as the risk-benefit ratio, as well as the cost-benefit ratio. So you may have modalities which are very beneficial but very risky, and that will have a high risk-benefit ratio. You may have certain interventions which are also very highly beneficial but are very expensive. So it may be described in the textbook, but it's very practical to do in the clinic. So all of these I have put into different boxes, the interventions that I just showed you. So if you look at efficacy, what do we mean by efficacy? So the intervention should be effective in solving the patient's problem, right? So if the patient's problem is poor vision in keratoconus, contact lenses have a very, very high efficacy in solving that problem. So if you fit a patient with good rigid contact lenses or scleral contact lenses, they will practically have normal vision, 6.6, at the most 6.9. And that's why it's very, very effective. Likewise, if your problem is progressive keratoconus, the keratoconus is progressing year by year by year, and you want to stop the progression, corneal cross-linking again is very effective. So typically papers will show anywhere between 75 to 85%, going up to 90% rates of stopping of the progression of ectasia with corneal cross-linking. And if you have both problems, if you have a keratoconus that is advanced, that is progressive, and the visual acuity is very poor, and a corneal transplant is done properly by a good surgeon and is followed up well, it again has very high efficacy in solving the patient's problem. Then lower down this ladder, you have things like ICL, you have things like surface ablation or PRK, which are moderately effective in solving the patient's problem, that is giving them good vision, but may not always be as effective as the ones which I have noted on the left side. And then you have the interventions which may be even lower down the scale in terms of efficacy. So if you put in intracorneal rings, you cannot really promise the patient that you're going to have 20/20 or 20/30 visual acuity. You would rather say, we'll see how it goes, and this will improve your astigmatism, will improve the surface curvature, which basically means you don't know how much it is going to improve the vision. The second parameter is safety. So contact lenses, it's not a surgery. So unless the patient has very poor hygiene practices, contact lenses would rate very, very, very high on the safety profile. Corneal cross-linking also, more or less, if you look at the published literature, the rates of complications are not very high. And likewise with surface ablation using eczema. Moderately safe would be a DALK or a PK, because every transplant has its set of risks. The same with anything that you put in the eye, like an ICL, or even if you do a CAIRS. And low safety, I've just put in ICRS because I've seen that evidence tells us over 100 years, 150 years, that any kind of artificial material that you put into the cornea, sooner or later, you're bound to have problems. So with a sufficiently long follow-up with artificial rings in the eye, you will see things like erosions, sometimes epithelial ingrowth, sometimes infection, sometimes the implant will extrude. And that's why I put it into the low safety box. And predictability. So what is predictable is very important to the patient. The patient wants to know what is going to happen whenever they undergo a specific procedure. Whether or not they are spending money is a different issue. So very high predictability is with, the highest predictability is with contact lenses, because you can actually do a contact lens trial and whatever you get on the trial is what you will get eventually when the patient wears the contact lens. So almost 100% predictable. Cross-linking, as I told you, is also quite predictable. It will cause flattening. It will cause stop the prevention, the progression of the ectasia. And some people might argue, but I would say that in good hands, even a DLK or PK is very predictable. Lower down the predictability scale, you have implantable rings and ICRS and PRK. So the risk-benefit ratio, contact lenses is very low, and everything else are put into the moderate risk-benefit ratio basket. Cost-benefit ratio, implantable collimator lenses, quite a high cost. Implantable rings, high cost. Very low cost would be contact lenses, and everything else would be somewhere in between. So now I come to my approach. So when we see a patient with keratoconus in the clinic, the first thing is to address the risk factors, because in our context, I would say almost 7 or 8 out of 10 patients with keratoconus will have some risk factor. Usually that risk factor is ocular allergy. So if you have a patient with ocular allergy and keratoconus, you need to focus on treating the allergy and not the keratoconus. Because until and unless you address the allergy, no matter what you do for the keratoconus, that intervention is not likely to succeed. The second, and this is what I tell all residents, is you need to treat the patient and not the eye. So each patient has different visual needs. Some patients might be very happy with 2200 visual acuity, 2060 visual acuity. Other patients will be more fussy. They have specific visual needs, and you need to tailor your management protocol according to that. So in general, these are the two goals of treatment in keratoconus. If it is progressing, we need to stop the progression. And if the visual acuity is poor or the vision quality is poor, we need to improve the vision, both in terms of the quantity of vision as well as the quality of vision. The most important thing that we forget is to give the patient different options and not just be paternalistic or tell them this is what you need. Because quite often the patient is not happy afterwards. So a lot of patients that I get, they have keratoconus, they have undergone corneal cross-linking, and they are very unhappy because they did not know why the procedure was done, what they should expect from the procedure, and what else needs to be done. For instance, they did not know that they would still need contact lens use. So I'll give you a few practical case scenarios and how I would tackle them. So if you have a patient who has keratoconus and the patient has good vision with glasses, has no other complaints, but is concerned and has come to you because someone has diagnosed them to have keratoconus. So these cases are the cases where I just follow them up without any intervention. So initially, if the patient is very young, I would see them every 3 to 4 months. If the patient is older, maybe 6 months to yearly follow-up. And contrary to what some clinicians advise, I do no prophylactic cross-linking. That is, unless I have clear and definite evidence in my hands that the keratoconus is progressive, and for that you need to follow up the patient for a considerable amount of time, I would not advise corneal cross-linking. These patients, if they have good vision with glasses, you have followed up for a long period of time, they are not progressing, and still they don't want to wear glasses, one of the good options is an toric ICL or implantable collimator lens, because you can promise the patient that whatever you are seeing with the glasses, you'll be able to see without the glasses. Nothing more, nothing less. Right. So this is the second category of patient where you have followed up for a period of time. The keratoconus is not progressive, but the patient does not have good vision. So this is where you should do a contact lens trial, do a corneal contact lens trial, a scleral contact lens trial. If the patient is happy with the contact lens, that solves their problem. They use the contact lens, as I discussed, it is low cost, low risk, and they have excellent vision. However, if the patient has very poor unaided visual acuity and the patient is unable to tolerate the lens or is not going to wear the lens due to whatever reason, then one might offer a DALK or, as the case may be, a penetrating keratoplasty. Right. So this is the third category of patient where you have keratoconus, which is definitely progressive, and you also have poor vision. So these are the cases where you have to be careful, because as the keratoconus is progressive, you would naturally advise them to undergo corneal cross-linking. However, if you don't have a specific management plan in in mind and you don't convey it to the patient about how they are going to solve their visual problems, the patient is going to be unhappy. So typically for these patients, I would do a contact lens trial as the first step. If the patient is happy with the contact lens, then we would go ahead with a corneal cross-linking, telling them that after the cross-linking, they can wear the contact lens. And that is the comprehensive management plan that I was talking about, where you're addressing the visual needs of the patient, as well as the scientific imperative to stop the progression of ectasia. However, if the patient is not happy with whatever plan you have for visual rehabilitation, the patient says that I am not happy with the contact lens or I am not having good vision with glasses, there is not much point in doing corneal cross-linking because the unhappy patient will remain an unhappy patient. And that is a patient where you would rather offer other modalities. For instance, you might want to discuss the possibility of a corneal transplant, which will address both these issues, the unsatisfactory vision as well as the progression in the keratoconus. And this is what I'm talking about. So to sum up this discussion, the most common modalities in my practice for management of keratoconus is contact lenses, a DALK or a PK if there is an indication for that. And I think corneal cross-linking comes lower down because I tend to follow up a lot of them without any intervention. So keratoconus has a variety of treatment modalities. And if you wish, I'll be sharing links to a few review papers where you can read about it. And that will help you answer your questions in the exams. But what you need to understand as a clinician is the patient needs and then set specific treatment goals for that particular patient. So the management plan should be individualized, it should be holistic, and it should be, this is very important, it should be documented on paper, right? And this is my preference. I prefer treatment modalities which have high efficacy and the risk benefit and the cost benefit ratio is acceptable to the patient. Thank you. If you have any questions, any comments, I would be happy to take them.
Thank you, Dr. Jayesh. Jayesh, when to suspect keratoconus? Actually, in my opinion, keratoconus is very underdiagnosis.
Yes, it's a very good question, sir. So all children with ocular allergy, according to me, should have corneal imaging at least at baseline and then onwards every 6 months or so. Some people may not have access to tomographers or topographers, but you can actually at least do the keratometry. And that will give you an idea of whether the cornea is steep or not. You can do pachymetry and see whether the cornea is thin or not. This is one thing, all patients with ocular allergy. Number two is patients who have significant change in the prescription of their glasses, in particular the axis of the cylinder and the magnitude of the cylinder over a period of time. And then the third is patients with astigmatism, where you're not able to refract them to 20/20 or 6/6. So these are my top 3 indications where you should do corneal imaging for keratoconus.
Sometimes patient is come with one eye diminution of vision with the scarring and other eyes clear cornea. I think one is that indication also for the topography.
Yes. If the patient has had high drops and scarring in one eye and you have not picked it up, you should be able to image the other eye and pick it up. So there is a question on the chat box by Manisha Singh, which is about the role of prophylactic anti-allergic on asymptomatic keratoconus patient to avoid eye rubbing. So there is no such thing as a prophylactic anti-allergic drop. The anti-allergic drop will only work if there is ocular allergy. So you have to determine whether the patient has allergy, and a lot of patients with keratoconus have allergy and you need to treat the allergy. Or you have patients, and this is a smaller group of patients, where they are just used to rubbing their eyes as a habit. So there it is more of counseling. You can give a placebo like a lubricant or something. Don't use steroids, don't use other drops, but just use lubricant and counsel them how not to rub.
Dr. Jayesh, sir, suppose a patient comes to a OPD of a general practice of ophthalmology practice. They don't have topographers and they have maybe manual keratometry. So what values would lead to suspicion so that maybe they can then get a topo done?
So if you look at the original Rabinowitz criteria, you have a cutoff of 47 diopters for keratometry. But I'm not sure. I mean, I may be incorrect, but does anyone have manual keratometers these days? These days? I'm not sure about that. In fact, more people in comprehensive practice these days compared to cornea specialists have access to corneal imaging. And even if they don't, it should not be very difficult to find someone in the vicinity who has a corneal topographer or tomographer. So I would say a cutoff of around 47 for the keratometry. And then if you still have a doubt, maybe refer them to a center which can do corneal imaging.
Dr. Jayesh,
Yes.
Pachymetry value.
Pachymetry, I really don't like to give a cutoff because it's very variable. So in general, Indian eyes or Asian eyes, the pachymetry values are a little lower than what is typically described for Caucasian eyes. So rather than 550, you'll have something like 510, 520, sometimes 530 as a normal. And there's really no cutoff. So you can have thin corneas without keratoconus. You can have relatively normal pachymetry and those patients still have keratoconus.
Sir, this is Dr. Rakesh Purwal.
Yes, sir.
I'm professor at Medical College Ajmer. Sir,
Yeah.
I just wanted to share what is form frusty keratoconus for the benefit of the residents.
Correct. So there are 2 or 3 terms, and this is important that Professor Porwal has brought it up. So you have keratoconus, right? So keratoconus is where you have made a definite diagnosis. So you have either clinical features or clinical features. Clinical features always mean that there will be topographic or tomographic evidence. Sometimes you don't have clinical features on the slit lamp, but you still have definite evidence on the corneal imaging. So that is keratoconus. What is form thrust keratoconus? So actually, this is debated, but what is commonly accepted is if you have definite evidence of keratoconus in one eye of a patient and the other eye of the patient has no evidence of ectasia, either clinically or on imaging, you would label that eye as form thrust keratoconus because you are assuming that keratoconus is bilateral. It is almost always bilateral. So that eye which is not showing any features of keratoconus right now, you're labeling as form thrust keratoconus, mainly to put up a red flag so that you can serially observe it with time, and also that you don't do any form of laser refractive surgery on that eye. The third category, which is sometimes used, is called a keratoconus suspect. So keratoconus suspect is not the same as form thrust keratoconus. Form thrust keratoconus, I hope, is clear. One eye of the patient, you are sure has keratoconus. The other eye has absolutely no feature of keratoconus. So that normal looking eye is what you call form thrust keratoconus, which means it has keratoconus that is not yet manifesting. Compared to this, keratoconus suspect is where you don't want to commit to a diagnosis of keratoconus based on your clinical evaluation and your corneal imaging, but you are seeing certain features on corneal imaging. So like I said, you may have thin corneas, or you may have steep corneas, but the pattern is regular. You're not very sure, and they fall into that intermediate zone where it's not clear-cut keratoconus. So you would say, I'm suspecting you may have keratoconus in the future, and we'll follow you up. So you would not do, for example, LASIK on such a patient if the patient is a keratoconus suspect, but you would also not do something like corneal cross-linking because you're not sure that the patient has keratoconus. So these are the 3 terms: keratoconus, form thrust keratoconus, and keratoconus suspect.
Thank you, sir. Thank you.
So there is a question from a student, Dr. Priyanshi Gandhi. A young patient aged 7 to 8 years has high cylinder of -3 in both eyes. Are there chances of developing keratoconus if there is no history of ocular allergy?
So there are always chances of developing keratoconus for anyone at any age, with or without allergy. But just cylindrical or power or astigmatism does not mean that the patient has keratoconus or is going to develop keratoconus. A lot of patients with very high astigmatism have regular astigmatism and have no evidence of ectasia on imaging. So the answer to your question is to do a proper corneal imaging, and that will tell us.
So one question from my
Yes, please.
Yeah.
sir.
Yes, I can hear you.
Is there any difference between diluted riboflavin or normal riboflavin used for collagen cross-linking?
Okay, so I have no experience with diluted riboflavin. The original resident protocol describes the use of riboflavin with dextran, and that is what is called isotonic riboflavin. Now, what we have access to is riboflavin prepared with HPMC. So that the advantage there is that it causes less intraoperative corneal thinning. And then there is a third kind, which is called hypotonic, where you want to swell the cornea artificially because the cornea is thin prior to cross-linking. So these three have different indications. But these days, more or less, the riboflavin with HPMC has more or less replaced the riboflavin originally, which used to come with dextran for almost all practical purposes.
Just one last question, sir. Is there any cutoff limit for the collagen cross-linking where the pachymetry is below 450, 400? Is there any cutoff, sir, where we should not do collagen cross-linking?
Yes. So if you look at the classical description and the resident protocol and the subsequent papers, what you should stick to is 400 microns after removal of the epithelium. So that is actually very difficult to achieve in a lot of cases. But in recent years, there has been a lot of work on trying to safely do corneal cross-linking in corneas which are thinner than that. So if you look at, for instance, the paper from Dr. Farhad Hafezi and their group, they have described a protocol where you can do corneal cross-linking safely, even with a pachymetry of, I believe, as low as 275 or 250 microns they've gone, although I would not go that thin, just by altering the duration of the exposure of the UV light. So the fluence that is delivered to the cornea.
Thank you, sir.
Yeah. But typically, the caveat here is that those very advanced cones with very thin corneas have very poor vision. So in any case, we are not achieving much by doing corneal cross-linking, unless, of course, the patient is ready to wear a scleral contact lens and has good vision. So those cases are good candidates for a DLK.
Thank you, sir. Thank you.
Dr. Jayesh, post collagen cross-linking, what would be the time when you would prescribe a scleral contact lens? What would be the time when you would expect things to settle down?
Typically, I would wait for about 3 months before prescribing glasses or any contact lenses.
And like what about scleral lenses versus ROS or RGP lenses?
So if they are already wearing lenses, I would ask them to resume their contact lens wear as early as 3 or 4 weeks after surgery, once the epithelium is healed, which is usually the first week. But if you're talking about a contact lens trial, a patient who has not worn lenses and is going to wear, then I would wait a little longer, because the corneal curvature tends to fluctuate dramatically in the first few months, and even later on can fluctuate a little. So I would do the trial after 3 months or so.
So which lens do you prefer in practice?
So the cones where you get a good fit and good vision with the corneal lenses, I would still prefer corneal lenses because of the cost and the simplicity. But the advanced cones where you don't get a good fit or good vision, then the scleral contact lens is a very good option. Also, cases of PMCD, scleral lenses are a very good option.
Yeah, and one more question regarding now PMCD. How effective is collagen cross-linking?
Not very effective. Not very effective.
Then, like, is there any other modality to stop progression?
Not that I know of. Not that I know. But generally, and this is the good thing, PMCD generally doesn't cause much of a problem. The cases that you see will be the 35, 40, 45 years of age, and someone will have incidentally picked them up. Of course, you have very advanced PMCD also, but there then the solution is more a corneal transplant than anything else.
One question from the Nisadi Naratna. Ron, can you read this? Nisadi. How frequently should we repeat topography according to age to see the progression? And should we do more frequently in teenagers?
Yeah.
And how to take decision of cross-linking according to the age?
Yes. So very good questions. Both the questions are very good. The first question is, how frequently should you repeat the corneal imaging? If the patient is young, let's say a cutoff of less than 20 years of age, after the first diagnosis of keratoconus, I would call them every 3 to 4 months for the first year. And if I have seen no progression for the first year, then I would call them every 6 months for the next couple of years. And if I have seen no progression for 3 years, then yearly for maybe another couple of years. So 3 to 4 monthly in the first year, then 6 monthly for 2 years, and then yearly for another 2 years. This is for patients who are young, less than 20 years of age. Patients who are more than 20 years of age, 30, 40, 50 years of age, I would call them once every 6 months for the first year. And after the first year, maybe you can just see them once a year or so. And the second question is about decision of cross-linking according to age. So according to me, the decision for cross-linking is independent of age. No matter how young the patient, if you have not established progression, I would not personally advise corneal cross-linking.
Okay. President, sir, any question? Dr. Sanjeev?
No question, but a comment actually.
Yes.
Okay.
I have observed in my practice and day-to-day work, there's a lot of people never document progression in keratoconus cases. The minute they diagnose it, they will advise corneal cross-linking. So like everybody has got these machines now, and everybody wants to keep up with the Jones. So the minute they diagnose, they will advise corneal cross-linking, which is not a good thing at all. Like you rightly pointed out, that you have to follow up and document progression before you do cross-linking. So that's one of the important take-home messages for everybody. And of course, Jayesh, is always a pleasure listening to you.
Right.
And your talks are always excellent. And there's always a nugget to take back home and store it for life, whether you are an uninitiated resident or you are a practicing clinician. So thank you very much for your excellent talk.
Pleasure. Thank you so much.
Any more question from resident? I think just we conclude the today's.
Sure.
session.
They can contact me anytime. So you can share my
Okay.
email address or phone number. If they have any questions related to their exams or any clinical issues, you can contact me anytime. And I'll share the literature that I said with sir, and he'll share it with you. Right.
So this has been a wonderful Kaksha on corneal dystrophy and ectasia. It's workup and the management. It's vast topic and it's impossible to cover everything. But it was a very well explained and a very comprehensive presentation by Dr. Jayesh. Thank you all residents, ROS executives, President sir, respected teachers, and especially Dr. Jayesh for the excellent teaching. We look forward to next class in the coming weeks and with more residents on the hot seats. Thank you and keep giving your feedback and suggestion for the Kaksha experience to improve. Do subscribe to the ROS official channel on YouTube. All previous Kakshas are uploaded there. And good night from the team ROS.
Thank you.
Good night. Good night, everybody.
Okay, good night, good night, good night.
Night, sir.
Good night. Good night, Manjula.